Thank you to everyone who has joined this breakout session. And thank you for braving the somewhat wordy title of this presentation. It's called After the X-Waiver, and it's about a curriculum that we're developing at the University of Michigan Emergency Department. But today's talk is going to be a little general about medication for opioid use disorder from the emergency department. So just for a little bit of introduction, my name is Aaron Krumheuer. I'm a third-year emergency medicine resident in the University of Michigan Emergency Department. I work under Dr. Eva Lozman and Dr. Shauna Smith. They are my mentors on this research project with the title After the X-Waiver. So disclosures, this project was supported or is supported by grants from NIDA and the Society of Academic Emergency Medicine. And first off, I'd just like to address my objectives for today. The first part of the talk, I'll be discussing the role of the emergency department in managing opioid use disorder. And the second part, I'll detail some of the efforts at the Michigan Medicine ED in implementing evidence-based treatment for OUD. I'll give you a little bit of introduction about myself first. So I'm originally from Ohio. I went to school in Southeast Ohio. I had a lot of friends from the area of Portsmouth, Ohio. If you've read the book Dreamland by Sam Quinones, that town, Portsmouth, plays very heavily in the book as part of one of the first real epicenters of the most recent opioid epidemic. So a lot of my friends, colleagues, friends of friends have been influenced by the opioid epidemic, either knowing someone who has struggled with addiction or know someone who's passed away from an overdose. So just, I think going to school in that part of Ohio really piqued my interest in opioid use disorder as something that deserves some attention. From undergraduate, I then went to medical school in New York City. It was there that I learned a little bit more about the preceding opioid epidemic. So as I'm sure a lot of you are aware, the current opioid epidemic we're in is not the first. There have been, of course, people who have used opioids and opiates for many decades. But starting in the 1960s and 1970s, New York City was particularly hit by heroin use. And this predominantly affected Black, Hispanic, and immigrant communities throughout the city. A lot of people working in New York City still have memories of when the opioid epidemic was ignored, very similar in some ways to the early stages of the HIV epidemic. There's a lot of stigma about people who use drugs, as there still is. But it definitely was a real lesson in learning about how race and sociodemographics play into, how we talk about and address this problem. So I did medical school in New York. I then arrived here to Michigan, pretty close to my hometown, about 2.5 hours away in Ohio, for my residency training. And I've been really fortunate to be able to work with a great group of folks here at the Department of Emergency Medicine, focusing on addressing opioid use disorder from the ED. So I'll just move on here. Opioids, the other epidemic. COVID has really captured the attention of our public health leaders, our medical professionals, basically everyone over the last 2 years, as it needed to be. However, the opioid epidemic has not in any way abated. Thanks to the excellent speeches this morning, we learned a little bit about the more recent statistics regarding opioid overdose deaths. As we can see here, it has not showed any yet real signs of slowing. If anything, we're still having continued acceleration of opioid overdose deaths. So why is that? Some would blame the social isolation from COVID playing a part in this, as well as limited access to inpatient recovery resources that so many folks are depending on, and that were cut short from either funding or concerns about quarantines during the COVID epidemic. Other folks, though, are more contributing to this fentanyl and the synthetic opioids that have seemed to rise in the illicit drug supply. But it's probably a combination of the two, plus other things we're not yet aware of. Just as all this to say that in the background of COVID, numbers are still increasing, and they are as well in Michigan. As you can see, our trends here follow those of the country at large in terms of escalating overdose deaths, unfortunately. I just wanted to here quickly look at the state of Michigan and its numbers of non-fatal overdose ED visits in Michigan. And this is month by month. And the reason I bring this up is because these are folks who made it to the emergency department. Perhaps they had been reversed by naloxone. Perhaps they did not yet take a lethal dose of an opioid, but for whatever reason, they were seen by a provider. If you can see here, the numbers don't show a real obvious trend. We're still seeing greater than 2,000 people per month in emergency departments throughout Michigan, people who have overdosed from opioids. This is an interesting graph because it shows us that the ED kind of holds a special place for folks who use drugs and who might suffer an overdose. It's clearly a point of entry. A lot of folks don't want to come to the emergency department, especially those who use drugs. There are some factors there we'll talk about later in this talk, but essentially, sometimes they have no choice, especially if they've just been revived and they're en route in an ambulance. So here in the emergency department, we see a lot of patients who come in after an overdose. We also see a lot of patients who come in with symptoms of withdrawal. We see patients who have skin and soft tissue abscesses and other health effects from using injection drugs. And in general, there are various other complaints that are accelerated or exacerbated by substance use disorder. So part of the reason I believe that the ED is unique as a source for addressing opioid use disorder is that it's a low barrier site. And what I mean by that is federal law, the EMTALA law, is a law that requires all providers to care for anyone who presents to an emergency department, regardless of their insurance status or their ability to pay. It doesn't mean that they won't eventually see a bill coming in the mail, but in a true emergency, the spirit of this law is that you will be provided with necessary stabilizing medical care, regardless. So that means that a lot of folks who don't have insurance, who don't have a primary care provider, who are not plugged into the medical system at large, will find themselves in the emergency departments when things are out of their control. Because of that, there are some new unique ways that I think that we can address opioid use disorder. It's important because this is a pretty real problem, especially with patients who present to the ED with non-fatal overdose. The 1-year mortality of these folks is as much as 6%, between 5 and 6%. Of those 2,000 people a month who are coming into Michigan EDs, that's about 100 patients a month who will die within a year. And then unfortunately, a good amount of those, about 1 in 20, passed away within about 2 days. So if you can think about why they might have passed away within 2 days, there's some indication that it could be from relapse or for perhaps using heroin again, although those details are not included in this study. This was a really interesting study, though. It included over 17,000 patients. The numbers are particularly tragic, however, because the median age of these patients was only 39 years old. It makes overdose presentations really a rare opportunity to intervene when you think about it. So let's see, what is there to do about it? Well, before the alarm bells were sounded regarding this current opioid epidemic, which has been going on over the last 2 decades, really the standard of care in the ED was monitoring patients until they were sober and then encouraging them to practice abstinence. Now, we now have a variety of interventions that we can draw upon, medical and otherwise, but I'll focus on medication for opioid use disorder as that's the subject of my research project right now. So first, I want to go through a few of the major publications that have come about in the last decade surrounding medication for opioid use disorder. So when we talk about MOUD, we're primarily discussing methadone, buprenorphine, and naltrexone. This is a great infographic about how OUD medications or MOUD works in the brain. So as you all know, we have many opioid receptors throughout our brain. They can become accustomed to a high level of opioid agonists in the form of oxycodone, heroin, what have you. When patients or individuals attempt to cease use of opioids, they're going to feel some withdrawal, especially from the great amount of opioid receptors that have been upregulated in the brain. There are a few medications that we use to try to plug those receptors, so to speak, to kind of simplify things a little bit. Methadone is a highly effective medication. It is a full agonist, and it is very effective at reducing cravings. Buprenorphine is a partial agonist. And then finally, naltrexone simply blocks those receptors. So that's kind of MOUD in a nutshell. So what works, what doesn't work? This was a retrospective cohort study of, I believe, the same 17,000 patients in Massachusetts who survived an opioid overdose over the course of about 2 years. It examined those who went either untreated, receiving either methadone, buprenorphine, or naltrexone, so 4 groups. Of those 4 groups, it found that buprenorphine and methadone were associated with all-cause and opioid-related mortality reductions. Naltrexone was not, at least in this patient population in this study. So as we know, especially among those involved in pharmacotherapy, this is really the holy grail, which is a mortality benefit. If you can demonstrate that a medication reduces your chances of dying, it immediately turns heads and precipitates and provokes more discussion and more studies. And so we'll talk about that here a little bit. We have potentially a mortality benefit, but there are also some other benefits to these medications. This Cochrane review, was a meta-analysis looking at 31 different trials. So that included about 5,000 participants, a little more than that. It showed that buprenorphine is an effective medication that retains people in treatment. So if you are on buprenorphine, you are more likely to remain in treatment, also more likely to decrease your use of opioids, or other opioids, I should say. And these are all based on placebo-controlled trials. So against taking essentially sugar pills. And finally, as relevant to the emergency department, this was a really landmark trial for us, and a randomized clinical control trial specific to emergency medicine. But basically took 300 people who presented to the emergency department, put them into 3 groups. One was a group that was only referred to an outpatient provider. The other group was given a targeted screening brief intervention. So essentially SBIRT or some motivational interviewing. And the third group was started on buprenorphine. So about 100 patients in each. Those in the buprenorphine group, 78% of those were still engaged in their treatment at 30 days, whereas less than half of that in the referral only group and the brief intervention group. So you're effectively doubling your chances that you're going to continue to stay in recovery. So we already knew that that buprenorphine has mortality benefit, but now we know when this came out that it's effective when you start it from the emergency department. And it's kind of where we come in. Suboxone is one of the names for buprenorphine, as I'm sure you know. It is our mainstay MOUD agents in the emergency department. That's because methadone, a highly effective medication, is not available for prescription in the ED unless a patient's already prescribed it. So In the year 2000, the Drug Addiction Treatment Act, DATA 2000, established a pathway for providers to prescribe buprenorphine. It essentially mandated that prescribers undergo an 8-hour training session in order to effectively initiate buprenorphine in patients. This is the X-Waiver, which I'm sure a handful of you either have or know very well about. It's called that because it requires, or the DEA requires, that you put an X before your standard DEA number when you write a prescription for buprenorphine. The 8-hour training session in order to earn your X-Waiver provided a lot of knowledge, and it was really helpful. It told you a lot about how to safely prescribe this medication. However, it's the only medication that I know of as a physician that I need to go and undergo an 8-hour training in order to prescribe. And when you look at the safety profile of this medication, it's not a very dangerous drug. We prescribe all the time much more dangerous drugs, even outpatients that have more side effects and risks than Suboxone. So the 8-hour training is pretty time intensive. Many providers have kind of issued this training because of that. For APPs, for advanced practice providers like PAs and NPs, the training is even longer. It's 24 hours. Even though the classes are often free, it does take a concerted effort in order to earn your X-Waiver. This has all changed in April 2021. Now, physicians need only to file what's called a notice of intent with the DEA and SAMHSA in order to prescribe buprenorphine. They can skip that previously mandated 8-hour training. So this is widely regarded as a pretty positive step. It's going to probably expand access and likely lead to a lot more providers. However, there's still some concerns that this is only one of many actions that need to be taken in order to train health professionals regarding MOUD. So several studies alone have indicated that the 8-hour X-Waiver training still left some knowledge gaps in readying physicians and providers to embrace MOUD. People who have had their X-Waivers might not always embrace buprenorphine, as they have lingering apprehension or concerns about diversion. I wanted to talk about that here a little bit. This was a pretty interesting study, and this is specific to the emergency department. It looked at 25 ED providers across 11 states. This included people who held their X-Waiver as well as those who did not hold their X-Waiver. It was based on focus groups, and they had open-ended interviews with a lot of different emergency providers and arrived at a number of really enlightening themes regarding why MOUD is and is not accepted. Other recent surveys of these emergency providers indicate that really the X-Waiver was a big part, but there are a lot more things than just the 8-hour time constraint. For instance, here's a few quotes that I wanted to share with you. I kind of already mentioned this, but one doctor says, I think it's insane that we had to do an 8-hour course for this, because I can give propofol, I can give all sorts of drugs that are much more dangerous. You can read through these if you want. Someone says, I feel like a lot of this was just not necessary. They could have boiled it down to 2 hours if they really needed to. Yeah, so people were happy that we don't need to necessarily do the 8-hour training anymore. But what else? Here's another quote from someone. They're concerned about their ability to ensure that a patient has adequate follow-up with an outpatient provider. So the quote says, I think the biggest barrier for me would be follow-up. If I felt like the patient had somewhere to go to continue to receive buprenorphine, that's what I'd want ideally. And the nature of emergency medicine is that we often only see patients once. And if we start them on what is a maintenance therapy, we want to make sure that they have good follow-up. So this study was enlightening and brought about some images of other perceived barriers. For example, some folks believe that opioid withdrawal is not a life-threatening emergency. And if someone comes to the ED with opioid withdrawal as a complaint, it's not necessary to instinctively treat it. This is not really true, as especially we know relapse is very much a life-threatening emergency, but it was something that was come across in this focus group. Other emergency providers are worried about job creep or scope of practice. So what essentially that means is they think that ED doctors are being asked to do more and more and to take care of more of the failings of the health system. Other people feel that there's too much complexity involved in prescribing buprenorphine, and a lot of providers feel they still lack knowledge about pharmacology. I think is what's interesting here about the perceived complexity of buprenorphine when they've asked follow-up questions about this. A lot of it has to do with the perception that if this medication needs an 8-hour training session, there must be something rather complex about it. And since I didn't undergo that 8-hour training session, I better leave it to the professionals and just send someone home without patient follow-up. So unfortunately, there are other barriers for ED providers for enabling or for embracing MOUD, and some of them is stigma. So get this quote: how much is it being abused? Are we enabling patients? Can we really trust them? Is it really something that we should do? Because then all the drug addicts in the country are going to come to us. So note the charged language here. There's clearly some pejorative views of patients still among providers in the emergency department, unfortunately. The study, however, was also interesting because it brought about and talked about some of the perceived facilitators. So why are people actually embracing MOUD from the ED? A lot of these have to do with things like their surroundings. So in the place that you work, does your employer say that, hey, if someone comes in with an overdose, you have to document that you offered them buprenorphine? So some places mandate this, which is good because it's evidence-based therapy. Peer pressures. There are some ED shops where the team of doctors and providers are very gung-ho about using buprenorphine. And so there's peer pressure that, like, you better do the right thing for this person. I include here neurobiology education because among a lot of clinicians, especially biomedical folks, Western biomedical folks, when you explain the neurobiology of addiction to them, it starts to frame opioid use disorder and substance use disorder as something within their wheelhouse, within their scope of practice, especially when you show them how receptors work and become gradually dependent on opioid agonism. ED champions, that basically means having someone who is spearheading the effort, sending frequent emails, congratulatory emails, cheerleading emails, saves and successes, and having an embedded, let's say, order set in your electronic medical health record also seems to help providers. ED-centric training is important because a lot of the X-Waiver training is not particularly focused on how to connect patients to outpatient providers. It's more about starting the medication. And then finally, patient navigators or paraprofessional support. By that, I mean, some places will have a navigator who, when someone comes in, either requesting buprenorphine or requesting more options to deal with their substance use, these navigators will help connect them to outpatient behavioral health specialists. Paraprofessional support is likewise the same concept. And then I think one inspiring component of this study was looking at, for those who already really adopted MOUD into their practice, there's a moral imperative to do right and compassion for these patients. That was really a persistent theme in the interviews, especially among those who were champions in their clinics. So I'll move on a little bit here. What about patients? So we know a little bit about what some of the ED providers think about buprenorphine and about caring for substance use disorder patients. What do patients think about the ED? I think this is an important question to ask. This study also looked at about the same number of individuals, about 31, and who had untreated opioid use disorder, aka they were not on any kind of medications. They participated in focus groups and they discussed their perspectives regarding going to the ED. So several important themes emerged, but primarily what the authors found is that these folks don't see the ED as a place that can really address their needs. And why might be a multifactorial question. I thought this quote in particular was telling. Once the hospital finds out that this is something that's part of your lifestyle, 9 times out of 10, you're treated completely differently. Growing up, we're always taught that we're supposed to be open with our medical provider so that they can give us the best care possible. And just a lot of places treat you like dirt. So it's sad. They describe that their pain is minimized when they present with injuries and illnesses once the providers learn that they use drugs. They describe encountering staff members who are hostile, who are judgmental, who do not know about MOUD or what types of treatments are available to them. And essentially, a lot of folks who use drugs don't go to the ED because they are going to be facing stigma and shame, and they don't see it as a place where they can actually access MOUD. Going along this theme, some people will turn to illicit means to get buprenorphine. So it is diverted. This was an interesting study that looked at a population of individuals who used non-prescribed buprenorphine, meaning they bought buprenorphine on the street. Overall, this group demonstrated that they were really using buprenorphine for self-treatment of withdrawal, much more so than they were using it for recreational use, although both were represented. But about 90% of use was described as self-treatment of withdrawal. Interestingly, this pattern of use was often centered around jobs and employment. Some individuals in the study described keeping a supply of buprenorphine for when work was available. A job opening came up, and that way they could use this to control their cravings, prevent withdrawal, accomplish this job, and then return back to their preferred use patterns. So also, though, there was a theme emerged in the study that those who did turn to illicit means to access buprenorphine often had difficulties initially with finding local providers, or they described the time and cost burdens of traveling to clinics, or dealing with insurance, or reconciling the terms of their treatment with competing obligations or personal expectations. So there's a few things to draw from that, and a lot more discussion that could be made. I wanted to change the subject a little bit over to the second part of my talk, which is a little bit more local. So I want to tell you about how the work we're doing here at University of Michigan Emergency Department is addressing some of these concerns, and generally open things up for discussion. I'll just start here first to tell you about some of the things that are in place at the U of M Emergency Department. These are not long-standing things, several years at best for most of them. The first thing, we practice, or we try to practice, safer prescribing. We have a prescription drug monitoring program embedded into our electronic health record. And this allows us to easily check the different providers and doses that are ascribed to one individual patient. And we can also check doses of buprenorphine if someone is engaged in outpatient treatment, should they need a bridging prescription or bridging dose. We also have take-home naloxone through a grant from the Michigan Emergency Department Improvement Collaborative, which was given to us through SAMHSA. And this is free for anyone who might be at risk for opioid overdose. We can just send them home with a kit. We also have embedded social workers here in our ED. They meet with patients with substance use disorder and provide a lot of resources. They provide linkage to outpatient treatment. They can provide linkage to harm reduction initiatives, for example, needle exchange, where to go, and where to seek therapy, behavioral and mental health resources, et cetera. We have the recovery opioid overdose team. And these are peer recovery coaches who will come to the ED after a patient is seen here with a non-fatal overdose and just provide support in any way that the patient really seems to need. And finally, since 2021, we have an addiction consult team in our hospital. So that's comprised of an MD, a social worker, an RN, a peer recovery coach, along with handling all the different consults within the hospital regarding patients with substance use disorder. The ACT group can come to the emergency department and be consulted to assist with treatment, to assist with linkage to treatment. A really great asset for us. But what about medication? which is what I've been talking about so far. So we know buprenorphine is able to reduce mortality. It decreases non-medical opioid use. It improves retention and treatments. It really is standard of care in the ED. But for whatever reason, prior to about 2021, we just really weren't prescribing it from the ED. There were very few cases where someone left with a prescription for buprenorphine after just one ED visit. And that's despite the fact that at that time, about a third of faculty and a third of our resident physicians, which is what I am, a doctor who's passed medical school, but is now in training to be a specialist in emergency care. So despite a third of all of our providers really having their X-Waiver, not many people were getting buprenorphine. So we wanted to figure out why, and we wanted to figure out a way to change that. We set out to develop a comprehensive curriculum to teach primarily our residents, such as myself, about opioid use disorder. And we wanted to confront some of perhaps their implicit biases when they're interacting with this patient population. Research has indicated that younger providers seem more willing to embrace MOUD than those providers who have already spent several years in practice. It's just one of the reasons that it's probably a good idea to address providers early. So this was our grants, NIDA and SAEMF gave us the funds to establish this curriculum and also to study it. It's divided into really two aims. The first aim is what I've just discussed. We want to evaluate what our residents know and don't know. And then the second aim is we want to use a framework for analyzing how what we taught them is changing practice. So here are some of the knowledge gaps that we identified. And this is a needs assessment that we had our residents undergo before we started our curricular planning. It was completed by about 90% of our class, which is 64 doctors. And they essentially showed that they, on one hand, already could pretty confidently identify patients who were at risk for opioid overdose. They could recognize risk for opioid overdose. They could recognize opioid use disorder, but they didn't know the details and the specifics. For example, the institutional policy. What does U of M say about what I can prescribe? The legal considerations. For example, am I allowed to write a prescription for buprenorphine? The options for outpatient linkage to treatments. They couldn't tell you a name or the names of the various addiction medicine or counselors out there in our community for which we could refer a patient. And then also the nuts and bolts of buprenorphine were a bit hazy for our residents. And finally, counseling substance use disorder in OUD patients was also something that they just didn't really feel comfortable in. This kind of highlights it a little bit better with some pretty colors. Essentially, our residents were very uncomfortable with, most of all, doing harm through buprenorphine, which is managing buprenorphine precipitated withdrawal. You never want to give a medication and then hurt someone. And then also dosing and managing the acute pain of people who are already on buprenorphine. And if you notice by this graph, no resident was very comfortable with any of these topics. So these became part of our curriculum, these subjects. What we did was create 6 hours of didactics, and the title of our grant was an abbreviated curriculum, since the X-Waiver training was 8 hours. But 6 hours of didactics, we had 6 separate sessions, and we wanted to fill in some of these knowledge gaps and also some of the confidence gaps. And started off with the grand rounds. So all of these training sessions were held during our weekly conference, which is a mandatory educational session that everyone more or less is free of responsibility to attend. So we have high turnout at these events, and we get a lot of people involved. It's kind of the weekly gathering of the department. So our grand rounds session was held by an addiction medicine trained doctor, Dr. Nathan Menke, who leads our addiction consult team. We then had 3 conference lectures, each 1 hour, and we spaced these out over several months so that we could practice some spaced repetition, so people wouldn't get too tired of hearing the same message or similar messages over and over. We had most recently a journal club where we met outside of class or outside of the hospital and talked about some of the major articles related to MOUD. And then we had a morbidity and mortality conference, which is, for those who are unfamiliar, M&M is when you look at real patient cases, and they're often cases that didn't go very well, and you talk about why. So you anonymize all the patient identifiers, but you get all the other details and you talk about them in front of a big group. It can be kind of a daunting experience, but it's a real tradition in our discipline, because it helps us to own up to mistakes, and also find ways that we could do things better. But also we use the sessions to highlight real saves and successes as well. So this was particularly well regarded, I believe. So as this point, all of the teaching sessions are accomplished, and it went pretty well. These were essentially our topics. I kind of went over some of these here already, and about really the importance of covering your bases, especially from the more obscure neurobiology to your bread and butter pharmacotherapy, like how to dose the medication. I also added in more about harm reduction than you would previously get in a X-Waiver training course, especially introducing ideas about needle exchange and harm reduction for other substance use patterns. And one thing that we found, and that is mentioned in the literature, and that's often neglected in, for instance, X-Waiver training, perhaps just because of the way it's designed, is that you don't often learn about your own institution's guidelines when you get trained on MOUD. So we made sure to make this front and center. We also made sure to include education about our outpatient providers in the community, as well as about the legality of prescribing this medication and what people really needed to know to just get started. So that's the first aim of our project. The second aim of our project was really to analyze how we're doing, so to speak. So we wanted to identify if there was any correlation between teaching residents and changing the practice at the U of M ED. And we chose the RE-AIM framework to measure these interventions. Public health folks in the audience might know some about this. For those less familiar with implementation studies, the idea is that you move beyond focusing solely on efficacy, and you look at broader uptake and broader success of an intervention. For example, really complex public health interventions would be difficult to measure in a randomized controlled trial. There are too many confounding factors. And so implementation science seeks to examine from a multimodal standpoint. You take into account not just like, does this drug work, which are important studies, but we also need to know, is it feasible to make this drug a part of our practice? So a central tenet of this model is that the ultimate impact of an intervention is due to its combined effects on various dimensions, and how this is all carried out among participants, patients, providers, clinical settings, cost effectiveness, sustainability, etc. Going through here about what this means for our project. Essentially, the reach analysis of our study looks at how many patients would benefit from MOUD who come to the ED, how many were offered it, how many agreed to initiate it, and then other things related to this. How many patients were offered take-home naloxone kits, how many were given instructions on how to reduce the harms of their substance use patterns, how many were connected to outpatient providers. Effectiveness is about, did what we do make a difference? And this is a more complex measure. We're looking at, for example, patients who presented again after coming in once for, let's say, an opioid overdose, came in for a second opioid overdose, who came in who were still using substance use or still using substances. despite being initiated on buprenorphine. Adoption is essentially how residents treat patients, noting the proportions of who offer it versus who do not offer it, and also who among the different job families offer it versus those who do not. For example, some attending providers see patients without residents. Do they write more or less buprenorphine? I for implementation is essentially how consistently we do this right. So it's like the fidelity of our intervention. So did we teach them appropriately? Are they dosing buprenorphine right? Are they monitoring for signs of precipitated withdrawal? Are they documenting or at least considering COWS scores for measures of withdrawal? And do they provide an appropriate prescription for buprenorphine at the time of discharge that will last them until they can get seen by an outpatient provider? And then finally, M is about maintenance. So this may be, let's say, very effective for 2 months, and then people stop doing it. And that's not a well-implemented project. So maintenance is about doing multiple post-intervention surveys to see if people still remember what they needed to know from the training. And this will all help us in some ways to make the curriculum better. Married to all of these concepts, we are able to record and to cross-examine all the socio-demographic variables of our patients as we look at who is getting buprenorphine, who's not getting buprenorphine, et cetera. This lets us do a little bit more of a health equity analysis. As you can see here, addiction rates versus treatment rates for those white patients. Addiction rates are middling, but treatment rates are really off the charts. So this represents a health inequity. By using implementation strategies, we can begin to look at broader trends among who we're prescribing and hopefully find out where our blind spots are or implicit biases are preventing us from doing good for all of our patients. So essentially the goals of the project, we want to change the culture around OUD in our emergency department. Hopefully we can draw some conclusions about what went well during this process, and then we can help perhaps share some of our resources with the wider field and improve on ways that buprenorphine training really needs it. So again, these were just our learning objectives. And this is myself and my mentors. And these are our resources. So I'll open it up to any questions or comments or disagreements or anything else that you'd like to talk about or not. I'm open. See a comment here, or question rather. So the question is, with a lack of outpatient referral points, what is your thought on why most hospitals or health systems do not have an internal clinic site to refer patients for follow-up after treatment initiation in the ED? That's a really great question. So essentially, why don't hospitals like U of M just simply have their own addiction medicine clinic? We do have one. It is full up, as I'm sure many of you can identify with. Yeah, we have a lot of patients who need help and not a lot of room to help them. But not only that there is unfortunately within the community mental health contract that this clinic signs that I believe they do not take a high proportion of Medicaid patients, and they take mostly private insurance patients, which is not very equitable and also really limits who we can send to that clinic. So the wait times are long. They don't take all kinds of insurance. Great question. There are some institutions that do have bridge clinics, and those would be places where perhaps you can't yet get a an appointment, we'll at least give you continuing care until you can find a more permanent counselor or provider. Good question. Well, I just want to thank everyone for tuning in today, and thanks for listening. I really appreciate it. Hopefully, don't see you in the ED at all. um, Not a place that most people want to end up, but I thank you for listening and for your interest. Really appreciate it.